Hi, it's Dr. Robert Seichert with another episode of Doctor Podcasts. We've gotten some great reviews and great feedback on the first two episodes, so I'm really excited to have another episode now. If you have any feedback, please get in touch with us through Twitter. And of course, if you like our episodes, please click on the follow button on the Twitter website, and also you can send us comments. My first two episodes, as you know, I spoke with eye doctors of various different specialties. Today, I'm really excited about speaking with a gastroenterologist. Dr. Daniel Alpert, who's sitting here with me, took time out from his very busy practice to be on Doctor Podcast today, and I'm very glad that he's here. Dr. Alpert is a gastroenterologist for many years. He's an attending physician at the NYU Langone Medical Center and the NYU Grossman School of Medicine here in New York City. And Dr. Alpert is one of the top gastroenterologists in the New York City area, so I'm really excited about having him here today. Thanks very much for coming today, Dan. I appreciate it. I have lots of questions for you, and I'm sure you have lots of interesting answers, and the audience look forward to hearing about it. One of the things that I'm reading about a lot lately, and also things that I see in my ophthalmology practice, is I'm seeing younger patients who've gotten colon cancer, occasionally even 40-year-old and rarely 30-year-olds. And I've also seen this written up in the literature recently. What do you think is going on? Why is colon cancer occurring in younger people?
Rob, first, thanks for having me. I really
my
appreciate
pleasure.
it. And thanks for taking the 2-hour drive to go from East 37th Street all the way to West 39th Street.
That was short. It usually takes 3 or 4 hours.
Yeah, we were lucky. So that's a great opening question. It is a very hot topic, and it is a real entity that we are seeing younger people under the age of 50 and oftentimes under the age of 40 being diagnosed with colorectal cancer. And many times these cases tend to be more aggressive than cases we are seeing in older patients. Now, in terms of why this has been studied, and thus far, the conclusions are that diet and lifestyle might be playing a huge role. Certainly, the biggest predisposing factor is family history. So about 20% of these patients who are diagnosed with colorectal cancer will have a family history of colon cancer. But there are other patients where there is no family history. So what are the common denominators? So what we're seeing as risk factors include obesity, a diet that is high in fat and processed foods and perhaps low in fiber. Certainly, we are seeing people with physical inactivity being a risk factor. So the combination of diets that are high in processed foods, high in fat, low in fibers, it seems to be are the major risk factors that we're seeing. Alcohol intake and cigarette smoking are other risk factors as well.
That's interesting that you mentioned that, because there are certain eye diseases that are also associated with obesity and inactivity and things like that, metabolic syndromes. So we recommend that patients eat lots of fruit, lots of vegetables, avoid processed food, avoid fats. And there's increasing evidence that exercise also reduces the risk of various eye diseases. So I guess that applies to the entire body. Right?
Absolutely. So as I mentioned, these risk factors as it relates to colon cancer, we could apply those same risk factors to a lot of cancers. We're seeing that all of those factors, obesity, low fiber diets, are contributory. So the more quote unquote plant-based your diet is, the better off you are. And those seem to be major factors. Now, there are other reasons why that could be, but diet and inactivity can actually affect your microbiome, something I think we're going to talk about a little bit later.
Right.
And the microbiome indirectly can increase changes within the colon, such that there's increased inflammation and ultimately cancer. And typically, when people develop colon cancer in the older age group, usually cancers arise from pre-existing benign polyps. The polyps that are pre-malignant are referred to as adenomas, and there's something called the adenoma-carcinoma sequence. And the whole rationale behind screening people is to look for polyps and to remove them. In younger people, they seem to have a different mechanism. A lot of younger people develop colon cancer seem to skip that adenoma sequence. So the whole molecular activity of the cancer is different. It's just behaving differently. And maybe
Yes.
the microbiome is playing a role in that.
So that's really interesting. So what do you recommend as the age that people should start having colonoscopies? Because I believe colonoscopy is the best way to diagnose colon cancer.
There is no doubt that the best modality to diagnose colorectal cancer and colon polyps is colonoscopy. That is considered the gold standard. Now, for the longest time, the recommended screening age for someone who is quote unquote average risk was 50. And by average risk, we mean someone who does not have a family history of colon cancer. There's not a history of inflammatory bowel disease. Patients who have ulcerative colitis and Crohn's disease have an increased risk of developing colon cancer. So somebody who's average risk, no symptoms, we would say 50. But because of what we just talked about, this younger population presenting with more advanced cancers, the age was reduced to 45 for average risk individuals. And my sense is that over time, I think that screening age is going to be reduced even further. It took time just to go from 50 to 45 to get the insurance carriers and everyone
Right.
else on board, which is part of the reality. But that doesn't mean that patients should not be screened earlier if appropriate. So I think it's an important teaching point that if a younger person has gastrointestinal symptoms, I have seen the situation where people sort of dismiss their symptoms, thinking, well, I'm young, it can't be anything too bad.
Right.
But people in their 40s, 30s, and even 20s are being diagnosed. So if you have blood in the stool, if there's a dramatic change in bowel habits, ongoing abdominal pain, you have to see a doctor. You should see a gastroenterologist.
Great advice. Let's say you have a patient who has a family history of colon cancer. Let's say one of their parents had it. And let's say they're obese and overweight, maybe have diabetes. What age would you tell them to have their first colonoscopy?
That's a great question. So one of the things you'd have to ask the patient is how old was the family member when they developed colon cancer? So there are recommendations that if there's a family history, that the colonoscopy should be done either 10 years earlier than the year that the person was diagnosed. If somebody was diagnosed when they were 45, you'd want to do it at 35 or the age of 40, whichever is younger. So that's sort of one guideline. Having a family history of colon cancer is significant, but if you have a family member who was diagnosed at an advanced age, let's say in their 60s, 70s, or 80s, it doesn't quite carry the same weight as someone who had a family member who was diagnosed earlier on. But clearly, you want to be ahead of the curve, and you want to be screened at least 10 years earlier than the index patient was diagnosed. And another important point is that if there is a family history, we have genetic testing available. And it can really help guide patients and doctors for how frequently they should be screened. So that's another important point. If there is a family history, especially if it's more than one relative, you definitely would want to pursue that.
On that same subject, is there a time when you don't need to have colonoscopies anymore? In other words, if you're 70 or 80 or 90, should you stop having them?
Right. It's another great question. It has come up a lot in the news. There was, not in necessarily the medical literature, but in a lot of magazines, television channels, et cetera, there were sort of statements suggesting that when you're 75, you should stop having colonoscopies. So I've had numerous patients come to me and say, well, I'm 75 now, I guess I don't need colonoscopies anymore. And the real answer is it has to be individualized to each patient. Certainly, if somebody is 75 and they're otherwise healthy, and they do not have underlying heart or lung disease, and let's say there's a past history of colon polyps or a family history of colon cancer, we should not stop screening. It's not as if the risk stops when you're 75.
Right.
But on the other hand, to exaggerate to prove a point, if somebody has advanced heart failure or they have metastatic cancer from some other site, or they have advanced Alzheimer's, you may not want to screen those individuals. So partially, it's a decision that the patient makes. Sometimes patients say, I just don't want to do this anymore. If they understand the risks and benefits, I think that's fine. But also, the physician should be involved also. Sometimes patients are just not medically fit to have a colonoscopy in terms of anesthesia, et cetera.
Right.
So it has to be individualized.
Right. I think we should stress that colonoscopy these days is a very, very safe procedure. and also it's not that uncomfortable with modern anesthesia techniques. Could you talk about that a little bit to encourage people to have colonoscopies?
A-
Because a lot of people are just afraid of the concept.
Absolutely. So one of the biggest advances in colonoscopy is the use of propofol.
Right.
And anesthesiologists are routinely involved in most colonoscopy cases. And the sedation that's given provides deep sedation. You're asleep, you don't feel anything, you don't remember anything. It's a painless procedure. The procedure is extraordinarily safe. As in any procedure, there can be risks related to anesthesia, perforation or tears in the colons are rare complications, but they are rare. So in good hands, the risk is incredibly small. So there really is no discomfort. It is clearly the test of choice. As I said, when we compare people who get screened for colon cancer and we compare them to people who don't get screened, the rate of colon cancer in the unscreened group is much, much higher. And that's been proven time and time again.
All right, that's a very important point.
Yeah.
What about these home tests? I see a lot of commercials on TV for Cologuard, which is a popular test and a very big company. Could you talk about that a little?
Yeah, well, I think for people who do not want to have colonoscopies for whatever reason, if they're fearful or they feel that perhaps medically they're not fit to have a colonoscopy, it represents some form of screening. But again, it does not compare to colonoscopy. And there are a lot of false positives and false negatives with polyp detection. And even their statistic on colorectal cancer detection, the statistic is that 92% of patients undergoing Cologuard who have colon cancer will be diagnosed. But that means that 8 out of every 100 patients who are tested are being told that everything is fine when in fact they have colon cancer. So it's
Right.
far from a perfect test. And ultimately, if the test is abnormal, you're going to need to have a colonoscopy to look in
Anyway.
further. So I think it represents some form of screening, but I don't think people should rely on it, quite frankly. There are other modes outside of colonoscopy where radiologic procedures are available. There's something called CT colonography, where you're using CAT scans to scan the colon. Again, not as precise, but it is not invasive. Still requires a bowel preparation. If something was abnormal, you would first need to have a colonoscopy.
Right. What about this camera device? I hear you can swallow a small capsule which has a
Right.
camera, and then it goes down your
That's
intestines.
right.
And
It takes a little
how
journey.
right? How effective is that?
Well, capsule endoscopy is primarily used not to evaluate the colon. It's primarily used to evaluate the small intestine. So there are certain indications when the small intestine needs to be thoroughly evaluated. And as you said, this capsule actually takes a video of your small intestine. So for patients who have gastrointestinal bleeding that is of unknown etiology, we don't know really where it's coming from, and the patient has already had a colonoscopy and an upper endoscopy to look in their stomach, and we still don't have a source, a capsule looks at the remaining part of the small intestine. It's also sometimes used to evaluate patients who have Crohn's disease, who have celiac disease, who have chronic abdominal pain and diarrhea that has not been diagnosed with other modalities. So that's where capsule comes in mostly.
Do any of those capsule movies wind up on Twitter?
All the time? No. Hopefully not. Hopefully not. Hopefully not.
All right, sounds good. Another topic, I see patients, when I see patients, I take a careful medical history because some medical conditions affect the eyes and so on.
Right.
So I see a lot of patients in the last few years with irritable bowel syndrome. Can you explain what that is and what the symptoms are and what you do about it?
Sure. So irritable bowel syndrome is probably the most common diagnosis a gastroenterologist sees. It's been said that about 20% of all visits to a gastroenterologist's office revolve around irritable bowel syndrome. And it's what's referred to as sort of a functional disorder, meaning that there are no structural abnormalities that we can diagnose. In other words, there's no test that tells us a patient has irritable bowel syndrome. So what is it exactly? Usually it's a syndrome of chronic abdominal discomfort or pain, oftentimes bloating. It can be associated with alterations in bowel habits. So there's what's referred to as diarrhea predominant irritable bowel syndrome, constipation predominant IBS, pain predominant. And we believe that a lot of patients who have this might have dietary issues. Sometimes emotional factors, anxiety or depression can be contributing factors. But again, We're beginning to learn more and more about the microbiome and
Right.
its influence on irritable bowel syndrome. That, in our colon, we have about 40 trillion microbes running around. That's a lot of stuff. And that some people who have irritable bowel syndrome might have a quote unquote imbalance or dysbiosis of good versus bad bacteria. So that's also sort of affecting treatment, that sometimes we will treat these patients with non-absorbable antibiotics that just stick to the gut and try to get rid of these quote-unquote bad bacteria.
I
But it's
see.
a very common condition. It's not serious or dangerous. It doesn't predispose to,
It's very annoying, though.
but very annoying. It can cause a lot of distress for patients. It could affect their lives and impact their lives tremendously. It does require a lot of patience on the part of the patient and the physician, because there's a lot of empiric therapy. So we try very basic things in the beginning: dietary manipulation, try to avoid fatty foods, increase fiber intake. Sometimes that works. When it doesn't, we try other things. So it's a process, but it's a very common malady.
Right. I've seen recently again commercials on TV for drugs for irritable bowel. Are there drugs that work for that?
Well, you might be referring to inflammatory bowel disease so inflammatory bowel disease is a different entity. That is, these refer to conditions where there's inflammation in the GI
I see.
tract.
So that's
And
different.
exactly, it's different. It includes Crohn's disease and ulcerative colitis. And there has been an explosion of drugs, what we refer to as biologic therapies. Here, there are ways that we can make definitive diagnoses based on findings on colonoscopy, CAT scan, MRI, even blood tests, and stool tests are helpful. But yes, there has been an explosion. But for irritable bowel patients, there are treatments, but not the treatments that you're seeing advertised on television. It's a different entity, but it's an important point, because sometimes it's hard to
Right.
make the distinction between who has irritable bowel syndrome and who has inflammatory bowel disease. So it requires a careful history, and sometimes tests are required to make that distinction, because there are conditions that can mimic IBS or irritable bowel that are not irritable bowel.
And again, you would need to do a colonoscopy sometimes to tell a
Sometimes,
difference,
sometimes,
right?
sometimes when it's not obvious, a colonoscopy can absolutely help make the diagnosis or rule things out for sure.
That's very interesting. What about you mentioned inflammatory bowel disease? There are two types. There's Crohn's disease and ulcerative colitis. Can
Correct.
you explain the difference between those two?
Sure. And sometimes the differences between the two can be subtle. And in fact, there's even a third entity, which is referred to as indeterminate colitis, where
Oh,
patients have features that might have a little bit of both. But with ulcerative colitis technically will only involve the colon. Whereas Crohn's disease, in theory, could affect any part of the gastrointestinal tract, from the mouth to the anus. So that's one difference. Another difference is that when Crohn's disease occurs, typically the inflammation is transmural, meaning that it goes across the wall of the intestinal tract. And as such, it can cause other complications, such as fistulous tracts, strictures, abscesses. That typically does not occur with ulcerative colitis.
I see.
And then there are other features. Ulcerative colitis tends to occur in the colon in a continuous fashion. Crohn's disease can be an Apache distribution. Those are some of the major differences between the two.
I recall for many years there was theory that they might be infectious conditions, possibly some bacteria or maybe a virus. Is that been proven at all, or still not?
There have been tons of studies over the years that have tried to implicate specific microbes, going back decades, tuberculosis, and other bacteria, but we've not really been able to identify a specific bug. However, it gets back to the microbiome again, that we
Right.
believe that people with inflammatory bowel disease may have microbiomes that have different concentrations of different bacteria that could be contributory factors.
Right.
There are others. There are genetic factors as well, but the microbiome is something that's being studied extensively.
Yeah, what's interesting is I have some patients who have these inflammatory bowel conditions, and very, very rarely they can get inflammation in their eye as
That's right.
well.
That's
That's
right.
very rare, but I have a few patients with that.
Absolutely. So these are inflammatory bowel diseases, and sometimes the inflammation is not always just confined to the bowel. Sometimes when there's activity, we have what we call extraintestinal manifestations. People can develop arthritis, uveitis, which is an eye condition, episcleritis.
Right.
They can develop something called primary sclerosing cholangitis, which affects the bile ducts. Can be very serious, which in fact can lead to cirrhosis and liver cancer. So there are a lot of these extraintestinal manifestations. And ultimately, these are inflammatory diseases. So the root of treatment is really to target this inflammation.
Interesting. What about the autoimmune theory of these conditions, that it's your immune system that's gone awry and somehow attacking your intestines?
That's exactly right. So that there might be certain uh, antigens or proteins within the bowel that your body or immune system is recognizing as foreign and inappropriately attacks it.
Right.
So, and that's why drugs like steroids and other immunosuppressants can be very effective for short-term relief, because you're suppressing that autoimmune anti-inflammatory response.
So the drugs that are available for Crohn's and ulcerative colitis are immunosuppressants?
They can be. There are immunosuppressants, drugs that include prednisone or other drugs that do what prednisone does. Uh, Imuran or azathioprine and 6-mercaptopurine are names of some of the older generation immunosuppressants. But over the past decades, there have been these newer drugs that are targeting specific inflammatory cytokines or markers that fluctuate throughout the colon, and we try to target those.
Right. I'm seeing ads on TV again for
Right,
those
a lot,
new
yes.
drugs as well. So these are pretty common conditions if they're doing a lot of TV advertising, right?
Absolutely. And for those people who are affected, it really has a tremendous impact on their lives. And again, there are more and more drugs being marketed, and there's an explosion of drugs over the last few years. And a lot of people are suggesting that ultimately a lot of these drugs will be combined together to optimize treatment. Because even though these drugs are terrific and have helped so many people, the response rate for most of these drugs is somewhere in the neighborhood between 30 and 45%. So there's still a lot of people do not have the kind of response we'd like to see.
Right. You mentioned the word microbiome a few times in relation to these various conditions. Can you just explain what that means? Because I think many people, or many of my patients, don't realize that there's trillions of bacteria living in their intestines. And could you just explain that a little
Yeah, I mean, a
more?
lot of people really don't know, because I think the microbiome is still in its infancy in terms of understanding it. But basically, there's a whole other universe in your gut of all of these microbes. And as I said, about 40 trillion would be the average, most of them being bacteria, some viruses, some protozoa or fungi. And it creates an important balance, we believe, for all kinds of things. It's sort of a regulatory mechanism. And the microbiome can be affected by diet, we believe we're coming to learn, certainly with antibiotic usage. We even believe that mood can affect the microbiome. So it's very fascinating. And basically, at this point, I don't think there's any disease that's not going to be studied as it relates to the microbiome. We believe implications with regard to cancer and cancer treatment and inflammatory conditions. So it's a fascinating area.
So basically, there are lots of different types of bacteria, and if you're lucky, you have the right ones that live happily in your body. They don't bother you, you don't bother them. But
That's
other
right.
people have too many of one type and not enough of another. The bacteria release chemicals and enzymes that can get into your body.
That's right. And one of the things that we think is really important in terms of having a healthy microbiome is having a diverse microbiome. And we think that that is connected to diet. So for people who have a diet that's varied and healthy, that actually can help promote a healthy microbiome. And for people who eat the same type of food, let's say processed food or fast food, their microbiome might be very narrow in its spectrum, and this can impact health.
So if too many of one type of nasty bacteria overgrows and kills other bacteria, that might be bad because they're releasing all sorts of chemicals
That's
into
right.
your
That's
body
right.
that affect various other
That's
organs.
right. And it raises, some of the things that we sometimes do or sometimes patients do even without physicians. Probiotics, the concept there is to try to alter that balance. There are certain antibiotics that are referred to as non-absorbable antibiotics. They go to work in the gut, but no place else. And hopefully they get rid of some of those bad bacteria. And then there are certain conditions, believe it or not, where people have something called a fecal microbial transplant, where you really try to transplant and give them a whole new microbiome. And
Right.
that is being studied, and it is used in certain conditions. There's a particular infection called Clostridium difficile, which is related to antibiotic usage. And sometimes when people have really severe cases that don't respond to typical treatments, fecal microbial transplants are being used and successfully.
Right. I've actually had a few patients who told me they had that. They caught a Clostridium difficile infection while they were in a hospital for some other reason, didn't respond to any antibiotics, and they actually had a
Exactly right.
fecal transplant
That's
from
right.
somebody else
That's right.
to give them new bacteria to kill
That's
the
right.
difficile bacteria.
Exactly right. Pretty fascinating. It's
Right.
amazing.
So we can kind of use these bacteria in
Yeah.
helpful ways.
Yeah. Who would have ever thought?
Yeah. Now you brought up the probiotics, which again many of my patients take because I take a history of what medications people are using because they can affect the eyes. So I noticed in the drugstores probiotics, a whole counter of them, and they're very expensive.
Yes.
Some of my patients swear by them and say they feel so much better. Others say, I don't know, it doesn't do anything.
Right.
What's the story with probiotics? The honest truth.
The honest truth. Well, in terms of what science has proven where they're helpful, it's only really a few indications. Clostridium difficile prevention probiotics are used. There's a condition called pouchitis, which is when patients have ulcerative colitis and they've had surgery. There's something called a pouch, and sometimes that gets inflamed. Probiotics have been shown to have a statistically significant impact on those two
Mm.
conditions. And also in pediatric patients, there's something called necrotizing enterocolitis where probiotics might be helpful. But aside from that, there is no real substantial literature to suggest that they help. Having said that, anecdotally, I have seen where sometimes probiotics can help patients, and whether it is really the effect of the probiotic or a placebo effect
Hard to
is
say.
hard to say and hard to know, but that's what the statistics or the data shows to date. There are certain situations where I recommend them. Sometimes when people have a GI bug and they have diarrhea, and you don't want to necessarily give them more antibiotics, and until you know exactly what the pathogen is, sometimes probiotics I find do help seem to lessen the course or the severity. And there are people who sort of echo that sentiment, but the data is not strong.
What's actually in the probiotic pill that you're taking? Can you explain that?
I mean, they're just different strains of bacteria,
Good
of
bacteria.
quote unquote good bacteria, bifidobacterium probably being the most important one, but there are other strains. Uh, of course, there are some people who take these probiotics who are healthy, and they just say, well, I'm going to take probiotics because I want to stay healthy.
Right.
But I would not recommend that, because who's to say that your microbiome, if you're not having any symptoms, is just as good as, doesn't need to be altered with.
Right. That's similar to the vitamin debate. Should you be taking a vitamin every day? Is that helpful or not? It, I
Right.
guess different thoughts and opinions about that.
Right.
So,
But if it's one thing if you're having symptoms, you want to try something, but for those people who are healthy, I wouldn't necessarily recommend it. But at the same time, what we don't see much harm being done by probiotics, but sometimes we don't necessarily see much good either.
right. What about another thing I see more of is patients who have a fatty liver problem. Can you explain what that is? That seems to be something that's increasing in frequency as well.
Absolutely. It's a huge topic now. And uh, so the story behind fatty liver, originally we knew about fatty liver as related to alcohol.
Right.
And one of the first stages of alcoholic liver disease was fatty liver, which was considered to be a reversible stage of fatty liver. So if you stopped drinking at that point, you would do better. And then we began to recognize that some people develop fatty liver even when they didn't drink alcohol. Who are these people? Well, it tends to be the same risk factors that cause diabetes, cardiovascular disease, what we refer to as the metabolic syndrome. So people who are overweight, who eat a diet that is poor, perhaps a lot of fat, perhaps foods with a high glycemic index, a lot of sugars or starches, and this is referred to as NASH, non-alcoholic steatohepatitis. And originally, it was thought that this is a benign condition. It would never cause chronic liver disease. It was not an issue. So if you had a fatty liver, we wouldn't really make too much of a deal about it. But now we've come to realize that that is not true. That
Hmm.
a lot of people with fatty liver, some of those people will go on to develop fibrosis, so that there's chronic inflammation and scarring. And then some of those patients can go on to develop cirrhosis, which is an irreversible stage of liver disease. And if you have cirrhosis from whatever cause, you're at increased risk of liver cancer or hepatocellular carcinoma. So we've really started to target these patients. And the treatment has to do a lot with the same thing a primary care doctor would tell their patient who has diabetes or high cholesterol, that you need to lose weight, you need to eat healthfully, you need to have a high fiber diet and try to cut out bad sugars and starches and fats. And we have all kinds of different tools to evaluate these patients.
The fatty liver means there's deposits of fat
That's
inside the
right.
liver
That,
that don't belong there,
that's
right?
right. That's right. So, and oftentimes you can see it on ultrasound. It's a very good, easy way of diagnosing it. So, if a patient has abnormal liver function tests, or a doctor is suspicious that a patient has fatty liver, an ultrasound will often show evidence of fat depositing in the liver. Uh, and that in and of itself may not be a bad thing, but over time, uh, the chronic deposition of fat leads to inflammation and fibrosis and perhaps cirrhosis. So this is a huge area of investigation right now, and it's one of the leading causes of chronic liver disease and even liver transplantation.
I'm again the ads on TV. I see this new ad for some liver pill keeps your liver healthy. Have you seen? I forget what it's called. It's on TV. There isn't such a pill, is there? That
Not that I'm aware. No. In fact,
right.
there are no drugs right now that are approved for the management or treatment of fatty liver. There are a lot of studies being done. So right now, the treatment really comes down to weight loss, healthy activity, physical activity. That's what it really comes down to.
Same thing that works for every other disease,
Exactly
right?
right. So that's what we're beginning to see. This is all sort of part of the metabolic syndrome, and now the liver is no longer being left out of that conversation. That's what it comes
Right.
down to.
Another thing that I see a lot of advertised on TV, as well as patients who have it, is gastroesophageal reflux disease, or heartburn, or acid stomach. It's referred
Exactly
to.
right.
There seems to be more of that as well.
There's a lot, yeah. So that's another very common disease state that gastroenterologists see. It's extraordinarily common, not just gastroenterologists, but primary care physicians. And that's the condition where acid from the stomach is inappropriately getting up into the esophagus. And sometimes that can cause symptoms, although sometimes it may not. There's something referred to as silent reflux. The classic symptoms would include heartburn, the sensation of a burning sensation in your chest, or regurgitation. But there are a lot of patients who may have symptoms that are not quote unquote classic. It could range from a chronic cough, chest pain, hoarseness, sometimes even sinus issues can be related to reflux. Now, what's the significance of all of this? Now, some people are under the impression, oh, if I have heartburn, it's not a big deal. I'll take an antacid, and if I get better, who cares? Well, the real issue is that if you have chronic reflux that occurs over prolonged periods of time, it could inflame the lining of the esophagus. And that chronic inflammation can lead to changes in the cells of the esophagus, something referred to as Barrett's esophagus,
Mm.
which is considered a precursor to something called dysplasia, which is a precancerous condition to esophageal cancer. And esophageal cancer is a terrible cancer, and the incidence of esophageal cancer is rising in this country. It's most common in white, obese males, but everyone is at risk. So there seems to be a shift, or some people are suggesting there should be a shift as to how aggressively we should screen these patients, because we're starting to see people who have esophageal cancer who had reflux, but were never diagnosed with Barrett's esophagus. So the question is Barrett's, are we missing Barrett's esophagus, or are there other histologic or cellular changes that are taking place that might be a predisposing risk factor that we're missing? The bottom line is, if you have reflux or heartburn, don't poo-poo it, don't dismiss it. You should have it checked out. It's important.
Right. Just a reminder, I haven't
Yeah,
been in medical school in a while. The esophagus, just a reminder, connects the back of your mouth and throat to your
stomach.
stomach,
That's right. It's
right?
the food pipe.
Right.
Exactly.
It's the food pipe,
That's right.
and that's where the cancer can occur
That's right. And
sometimes.
so it's a food pipe. It's about, to the tip of the proximal part of the top part of the stomach, about 40 centimeters. And besides cancer, there are other things that reflux can do. So sometimes the chronic exposure of acid can actually narrow the lumen of the esophagus. So if you think of the esophagus as a tube, sometimes that tube gets narrowed and people develop strictures. And then what happens is that sometimes food gets caught in these strictures. We used to refer to it as steakhouse syndrome, because the classic situation is
Right.
somebody's, at a steak dinner and they're having a good time, and maybe they're not being very careful with the size of the steak that's going down their gullet.
Good
And the
steak.
next thing they know,
Right, it's stuck.
so, we have to be careful. Now, besides medication, diet actually plays a big role again, and that's important. And I always tell patients or kid with them that anything that is pleasurable or enjoyable can cause reflux. So it can range from alcohol of any variety, including beer, wine, caffeine, fatty foods, fried foods, chocolate, spicy foods, acidic foods. It's a long list.
So basically, you just want to eat like carrots and lettuce.
Basically,
That's
yeah,
it.
maybe it's an occasional piece of chicken if you're behaving, So that's part of it. And then, and for some people, just adjusting their diet might be enough, but for others, medication is necessary. And there are different classes of medications, and there's some controversy about long-term use of some of the medications we use, called proton pump inhibitors, which are the strongest or most potent medications, and they work the best. But there have been some concerns raised about long-term use, although most gastroenterologists really view them as generally safe drugs. But at the same time, if somebody doesn't need to be on it chronically, it's the doctor's responsibility to try to de-escalate or de-prescribe once the patient's symptoms are under control. So it's something that we have to always be mindful of.
Oh, interesting. A lot of conditions that affect the gastrointestinal
Yes,
tract. I
yes,
guess
it's a long list,
it keeps you busy.
for sure.
Now, the hottest topic, and the reason I really have you here today, is I want to know about gluten.
Aha,
Because everybody now is gluten-free. Gluten
right,
is like the worst enemy in the world.
right.
What's the story with gluten? Why did I never hear about it for decades, and all of a sudden now everybody has a gluten sensitivity or problem?
Right. It's pretty amazing. Actually, if you go into a large supermarket, there are often entire aisles that are just dedicated to gluten-free foods. Now, gluten was really made famous by a disease called celiac disease, which again is an autoimmune disease, and it's a kind of an interesting disease. When you ingest gluten, which is sort of a protein mix that's seen in wheat and barley, rye, and oats, people develop this autoimmune reaction. And if you remember high school biology, in the intestine, there are these little finger-like projections called villi, and they're there to help absorb nutrients. And in people who have celiac disease, they have antibodies that are present that produce this sort of destruction of villi and what's referred to as lymphocytosis. There's infiltration of white blood cells, and the absence of villi causes patients to have these unpleasant symptoms of bloating, gas, and diarrhea. So that is clearly a gluten-related disease, and the treatment for celiac disease is to be strictly gluten-free.
Okay.
And in fact, when people go into remission from being gluten-free, the single biggest reason why they flare is because unknowingly there is some gluten getting past their lips. So even when people are exquisitely careful, they can have relapses. Often occurs in a restaurant's setting where, perhaps the kitchen is not being very, very careful and there's cross-contamination. Now, for the rest of the world, why do they need to be gluten-free?
Right.
So we don't really know, and it's sort of a fad. When we look at the number of people who have celiac disease, it's a small percentage. The literature will say 1%, 2%, 3%. I don't think it's more than that in my experience. And this issue of gluten intolerance is sort of a controversial topic. I mean, I sort of believe that it can exist, that people, when they have gluten, it just doesn't agree with them. They don't actually have the autoimmune disease. But I think that it has taken on a life of its own to be gluten-free. There are certain athletes that are gluten-free.
Right.
They feel that it helps their performance. And, again, whether this is sort of placebo effect or not, we don't know. But it's also not necessarily the best thing to be gluten-free if you don't have to be, because there are certain nutrients that people are deficient in when they're sometimes gluten-free. So if you don't have to be gluten-free, you shouldn't be. But there are patients I've encountered through the years who insist that they have gastrointestinal symptoms that respond only to eliminating gluten from their diet. And if they do and they feel better, it's hard to argue with that. So we
Right.
go with it. I go with it.
Yeah, the bottom line is if it makes you feel bad,
That's right.
don't take it.
Exactly.
But there is a blood test to check for the celiac
That's right.
version.
So for people who have, you're absolutely right. So for people who have celiac disease, it's a great screening test. There are blood tests that are antibodies that are only present in people, should only be present in people who have celiac disease. Well, the one is something called transglutaminase antibodies. That's very specific for celiac. There are others that are not quite as specific or sensitive. So it's a good screening test, although we consider the definitive way of making the diagnosis having the patient undergo an upper endoscopy and biopsying the small intestine and looking for the classic histologic features, which are the absence of villi, those little finger-like projections I was telling you about, and something called intraepithelial lymphocytosis, this infiltration of a certain type of white blood cells. That's a definitive way. But the blood tests are very helpful for monitoring patients and diagnosing patients, absolutely.
All right, that's great. Can you explain what upper endoscopy is?
Sure, I should not have assumed that everyone knows. So an upper endoscopy is like a colonoscopy, but we're looking at in another orifice. So it's an examination where a flexible tube is inserted into the mouth. And again, this test is also done under sedation with propofol. And it gives us the ability to examine the esophagus, the food pipe that leads into the stomach. And we can evaluate the stomach and conditions of the stomach, including but not limited to peptic ulcer disease, Helicobacter pylori, which is a bacterium that can cause peptic ulcer disease, cancers of the stomach and esophagus. And then we can also look at the small intestine where we can diagnose things like celiac disease or digestive enzyme deficiencies, referred to as disaccharides deficiencies. So an upper endoscopy is actually a really important tool that gastroenterologists use all the time.
And it's also done under propofol. Propofol is a great drug. I use that often when I do eye surgery on patients who are extremely nervous. They love it. They don't feel anything. They wake up feeling refreshed like from a long nap. It's a great drug.
It is great. You know, it's interesting because there are some people who are so nervous and reluctant when they're having the procedure. And then when the procedure is over, they'll often say, that was awesome. That was the best sleep I've ever had. I feel so good. Can we do this again? So, you know, the thought of a colonoscopy and endoscopy is actually much worse than the actual procedure. It's actually,
Right. So you mentioned a few procedures that gastroenterologists do. Can you tell us what you do during a week, what procedures you do, what types of patients you see, how your time is?
Yeah, I mean, I would say, you know, a typical workday may involve starting off rounding in the hospital and then coming back to the office. And gastroenterologists, I mean, there are, I would say, two major divisions of what we do. There is consultative work where we're seeing patients in the office who are presenting with new complaints or issues, or we're following up on patients who already have diagnoses. And then there are times we have to do procedures on patients to help make those diagnoses. So a lot of my time, the majority of my time is spent seeing patients in the office. And then there are 3 days a week or 3 mornings a week where we do procedures. Some of the tests that we mentioned, upper endoscopy, colonoscopy. We also do capsule studies. And there are other tests that gastroenterologists do. There are tests that include something called ERCP, endoscopic ultrasound, liver biopsies, and there are specialists within the world of gastroenterology, and there are specialized tests of the esophagus, and it's a fascinating field, and that's why I love it. It's a combination. It involves so many different organs when you think about it. It's the esophagus, the stomach, the small bowel, the large bowel, the colon, the liver, the pancreas, and that's what makes it so interesting to me.
Yeah, we spoke about different cancers that occur in different parts of the gastrointestinal tract. I'm also hearing and seeing more patients who have pancreas cancer.
Yes.
Why is that? Do we know?
Well, I mean, I think we're getting better at diagnosing it. We have good imaging, but it's a horrible disease. I mean, my own father had it, was diagnosed with it. And oftentimes, unfortunately, when people are diagnosed, by the time they're diagnosed, the cancer is already at least locally advanced. There have been tremendous strides made, I would say, over the past decade in terms of treatment. So for those people who are able to have what we call resectable disease, there is surgery, a Whipple procedure, which is major surgery. But I have observed that a lot of the chemotherapeutic regimens have improved, and there are people who are living longer. But we have MRCPs and ERCPs and endoscopic ultrasounds. These are all different modalities that we have to diagnose and follow people with pancreatic disease.
Are there any risk factors for pancreas cancer that we can avoid, or not really?
It means there certainly could be genetic or family history can be one factor. Like in a lot of cancers, certainly cigarette smoking has been implicated, alcohol has been implicated. Sometimes there are certain conditions of the pancreas. They are aware of something called hereditary pancreatitis, which can lead to pancreatic cancer. So genetic factors certainly play a role.
Does alcohol
It
affect?
can. Well, alcohol certainly can cause something called pancreatitis, both acute pancreatitis and chronic pancreatitis. So people who have a history of significant alcohol abuse and pancreatic injury can secondarily often go on to develop pancreatic cancer.
The pancreas also produces insulin, which controls your blood sugar as well. So the pancreas is a complicated
Absolutely,
organ.
that's right. So yeah, that's right. There are endocrine cells like insulin, and then there are exocrine cells, enzymes that are produced that help aid in fat digestion. So when you have a pancreas that's not working, it can cause all kinds of issues, including diabetes, including terrible diarrhea we call steatorrhea, where you're malabsorbing fat and you have diarrhea on that part. Because if you have a damaged pancreas, it's going to impair your ability to properly digest fat. So that's specifically for people who have chronic inflammation of their pancreas.
Right. Speaking of diabetes, again, comes up in various disease states. I have patients now, I'm sure you do, who are taking Ozempic, Wegovy, Mounjaro to lower their blood sugars, keep their weight down.
Right.
And some of my patients tell me they've tried it and have had stomach issues and problems.
Correct.
Are you seeing some of that?
Yeah, I mean, of course, as a gastroenterologist, I'm not necessarily prescribing these drugs, but I would
Right.
see patients who are on them, and the most common side effects that we see are happen to be gastrointestinal. Sometimes people complain of nausea, sometimes vomiting, crampy abdominal pain, diarrhea. So sometimes these medications need to be adjusted. Sometimes these side effects are transient and people sort of get better. Uh, but we do see that. And actually, one of the drugs that you mentioned, Ozempic, can actually increase the risk of pancreatitis as well. That's more significant. So for patients who've had a history of pancreatic disease, we'd want to be careful about using those drugs.
Well, that's interesting. What new things are coming up in gastroenterology that you think will impact how you treat patients in the next, let's say, 3 to 5 years?
Well, I think if we can pick any organ system, there are advances going on in all. I think we touched on some of them. And certainly, there is an explosion of new drugs for the management and treatment of inflammatory bowel disease, and the treatment of those conditions is rapidly, rapidly changing. And now we use different drugs that have different mechanisms of action, and I think we're going to see these drugs being combined to get better results. So I think that's certainly one area. Irritable bowel syndrome, which is not necessarily a serious or dangerous condition, but impacts people. I think the microbiome might play a big role there and will influence how gastroenterologists practice. And we touched upon fatty liver and fibrosis of the liver and how that's going to impact uh, uh, incidence of cirrhosis and chronic liver disease. And I think there's going to be an explosion of treatments to address that as well, besides just diet and lifestyle
Right.
changes.
Now, I know at NYU, at the NYU Langone Hospital Medical Center and the NYU Grossman School of Medicine, they're doing a lot of new types of imaging to help diagnose some of these conditions. Can you?
I mean, NYU has done a tremendous job in gastroenterology. We have specialty centers in inflammatory bowel disease, liver disease, esophageal disease, and we also have a lot of great uh, radiographic uh, technology to use. So, for instance, in the case of the liver, there's something called MR elastography, where we're using MR technology. We can actually measure the stiffness of the liver, and that's thought to correlate very well with the patient's underlying liver disease.
Hmm.
When we talked about screening the colon, CAT scans now incorporate something called enterography, where we can now really visualize the intestinal tract a lot better than we used to. And for people who are not able or do not want to have regular colonoscopies, there's something called virtual colonoscopy. And I believe NYU is one of the first centers to do that, where we can really look at somebody's colon and see whether there are polyps or growths, and they do a terrific job. So yeah, there's a lot being done at the medical center.
Do you think the imaging will ever replace colonoscopy? Or
No, I don't think it
No.
will, simply because colonoscopy has the advantage of being diagnostic and therapeutic at the same time. We have the ability to take biopsies to remove
Right.
polyps, and that's the advantage. But for
So
people,
while you're there, you can, if you
That's
see
right.
something suspicious, you can biopsy it at the same time, as opposed to
Exactly
having
right.
imaging and then they have to go
That's
see
right.
you to get the
So
biopsy.
so if you have imaging and something is seen that's abnormal, you will first need to have a colonoscopy, and even the virtual examinations do require preparation, which is probably the most difficult part of having a colonoscopy. So it means having two preparations instead of one. But there are certain circumstances where it is helpful and it is necessary, and it's a nice tool for us to have.
That's great. So we've covered a lot of topics in
Yeah, we have.
gastroenterology. And how many years of training after college did it take for you to become a gastroenterologist?
Right. Well, so there's medical school. So I guess so that's 4 years of medical. That's
4.
four. When I went, I guess I got away with something because we had medicine residency, which is 3 years. Now GI fellowship is 3 years. When I went, it was 2 years.
Oh,
And then there are fellowships now where people even go beyond the 3 years. There are subspecialties within gastroenterology. So
so
for,
you did 4 years of medical
right,
school, then
4.
3 years of
That's right. So
residency.
up to
So
7.
you're board certified in internal medicine as
Correct.
well as
That's right.
gastro.
So,
And then you did 2 years of fellowship.
correct.
So that's only 9 years.
I know. I got
You
got
know,
off easy. I know.
by
Well,
the time you were done, you're almost ready to retire.
I know. I mean, listen. I mean, that's one of the things that people don't necessarily appreciate. But yeah, it's a long road. It's a long, hard road. And residency ain't easy because your typical work week, it's not a 9 to 5 situation.
No.
We like to call it the days of the giants, but you would go in on a Monday. If you were on call that night, you started Monday morning and you didn't come home until Tuesday night. And if you were working
Right.
in the ICU or the CCU, you were on call again every third night. So the whole pattern repeats itself. So yeah, it's
Right. I did a medical internship before my ophthalmology residency, and I was on call every third weekend where I would start work Saturday at 8 a.m. and work through Monday, 5 p.m. And occasionally there were weekends where there was very little sleep. And I'm sure you
oh yeah,
experienced the same thing. That's
absolutely.
probably too much, and they've
Yes,
now restricted
absolutely.
that, which is a good
I think it's a
idea.
good thing. Yeah, it's a good thing. The main teaching hospital in NYU is Bellevue, and that's a busy place. And we've instituted night floats, which is better. It's more humane, and I think people are more likely to function better, quite frankly. So I think it's a
Right.
good thing.
Well, this has been a great discussion. I
Yeah, no,
really
thanks so much for having me,
want to
Rob.
thank you for taking time to come here and explain all these things. I think the audience will learn a lot from
I hope
this.
so.
And if you have any comments or suggestions, please get in touch with us. We'd appreciate it. And I'm looking forward to some more Doctor podcasts coming up very soon. Thank you.
Thank you, Rob. Thanks for having me. Great.
All right.
Okay, sure.